Hello and welcome everyone to today's webinar, Implementing New Crisis Services, the View from the Ground Up. This is the third and final webinar in a three-part series on the topic of behavioral health crisis response services. We are absolutely thrilled that so many of you could join us to learn more about this critically important topic. My name is Sarah Kopelovich. I'm an assistant professor in the Department of Psychiatry and Behavioral Sciences at the University of Washington and core faculty on the Northwest Mental Health Technology Transfer Center. On behalf of the entire Northwest MHTTC, I'd like to welcome everyone to today's webinar with Dr. Michael Flaum, Emeritus Professor of Psychiatry at the University of Iowa Carver College of Medicine. Before we get started with this very important topic, I want to say just a few things about the MHTTC network, which is a national network supported by the Substance Abuse and Mental Health Services Administration, with the purpose of disseminating and implementing evidence-based practices for mental health disorders into the behavioral health workforce. The MHTTC network consists of a national coordinating office, 10 regional centers, a tribal affairs center, and a Hispanic and Latino center. Together, our network supports resource development and dissemination, training and technical assistance, as well as workforce development to the mental health field throughout the United States. Broadly, our goals at the Northwest MHTTC are to heighten awareness, knowledge, and skills of the workforce addressing the needs of individuals with mental illness, to accelerate the adoption and implementation of mental health-related evidence-based practices across our region, encompassing Alaska, Idaho, Oregon, and Washington, and to foster alliances among culturally diverse mental health providers, policymakers, family members, and clients. It's our intention to always be mindful of using language that promotes recovery and culturally appropriate terminology. We encourage all clinicians to use and champion person-first language, which emphasizes the individual rather than a condition or a disability. Before we get started, I'd like to take a moment to introduce our speaker today, Dr. Michael Flaum. He is an Emeritus Professor of Psychiatry, as I said, at the University of Iowa, Carver College of Medicine, and the author or co-author of more than 100 publications, reflecting his collaborative clinical research in schizophrenia in the 1990s. In 1999, he assumed the directorship of the Iowa Consortium for Mental Health, which aims to harness the academic resources of Iowa's universities to benefit the state's public mental health system. His work since then has focused on efforts to optimize the quality, effectiveness, and access to psychiatric services within publicly funded settings in a recovery-oriented manner. He currently serves as president of the American Association for Community Psychiatry. Without further ado, I will now turn it over to Dr. Flaum.
Thank you very much. I'd just like to welcome everybody. This is going to be a non-COVID related webinar. This is the first non-COVID related webinar I've participated in a couple of weeks. So I hope that's a welcomed relief for you. I'll tell you that this was prepared well before all of the COVID related things, and I did not update it to make it COVID relevant. So that's a little bit of a disclaimer. Like many of us, I wear many hats. One is I spent my career at the University of Iowa Hospitals and Clinics, where I just retired from my full-time job about a year and a half ago and I'm now in the very pleasant position of just doing things that I really care about. And the things I'm talking about today are among those. My main clinical focus of interest has been in adults with serious mental illness, primarily psychotic disorders. And as was mentioned, I had this role of being in a public academic liaison for about the last 18 years of my time at the University of Iowa. I think the next thing that you should see is the gap. And the reason that's particularly important for this presentation is that many of you, and we'll find out in the poll how many, may have participated in the first two webinars in this series, one by Dr. Balfour and one by Dr. Minkoff. and I work with them in the GAP group, as well as on the board of the American Association for Community Psychiatry. So I am really close to the work that they do through our GAP work and the document that Dr. Minkoff described in his webinar on the ideal crisis system. And again, through my role in the American Association of Community Psychiatry, that gives me a nice sort of view of what's going on in the national and even international picture in this area. That just suggests that another role that's important is that I am a community member in my own community. And I'm going to talk today about the efforts in our local community. So let's get a bit about you first. And if you guys could run through these polls. So we'll take maybe a half a minute. Which option best describes your role? Forgive me if I didn't capture all of you. I see a couple of peer specialists, which that's great. A lot of other mental health treatment providers, state program specialists, that's great. A lot of administrators. Okay, I'm going to end this one and go to the next one. In which kind of setting do you primarily work? So are you primarily inpatient, outpatient, addiction, ER, crisis center, other? And I'm seeing lots of outpatient pop up, about 25%, and lots of other, mostly other. All right, I think I'm going to end this poll and go on. Poll 3. So this is important for me to know. How many of you participated in both of the previous webinars? Only the one by Dr. Balfour, only the one by Dr. Minkoff, or is this your first? So I'm getting a lot of firsts, which is important for me to know. I'll tell you right off the bat that I would recommend that you access the recorded sessions because they both really offer a lot of important information. So given how many people answered that this is the first in the series, I just want to go on and say a little bit about the first two sessions. So Dr. Margie Balfour is a colleague I work with very closely, and she is the Director of Quality and Improvement for two of what I see as really the leading edge crisis centers in the country, one in Phoenix, Arizona, and one in Tucson, Arizona. And not only does she do a wonderful job really directing as the medical director, I believe she's the medical director of those two crisis centers, but she has really done amazing work in helping people like me and my community in thinking through what the sort of standards and how we look at the goals that we want to achieve and the outcomes that we want to achieve. And we've been using her as a consultant in our development of a community-based access center. And Dr. Minkoff presented on an ideal crisis system, a document we in the Group for Advancement of Psychiatry have been working on for the last 2 years or so, and is getting toward a near final form, in which we're trying to lay out sort of guidelines at a national level that would help communities like mine to assess where they are in their evolution of development of good crisis services, and inform how to proceed at all levels. So what I'm going to do today, those are really the academic presentations. Dr. Balfour runs what I think of as the state-of-the-art crisis system, and Dr. Minkoff presented sort of how communities could look at the big picture and start implementing programs. And my job today was really about a very nuts and bolts, one community's experience of dealing, of trying to enhance their crisis services. And I'll talk about two things that we did. One is establish a hospital-based psych ER that we call a crisis stabilization unit, and which opened about a year and a half ago. And then another is the development of a non-hospital-based, community-based behavioral health crisis/access center that we are very much in the process of opening, scheduled to open this fall. I'm going to try to give you a sense of the process that got us there. I won't take a terribly long time to do that, but my main point is that this, at least in our community, has been a greater than 10-year process, which seemed necessary. And I'm going to talk a little bit about our progress and some of our challenges. So where this began, at least for me, in my role in the Iowa Consortium for Mental Health and in my role at the University of Iowa, is for reasons that frankly remain a little bit unclear. We were seeing in our general emergency room at our large academic university hospital a dramatic increase over a period of about 5 years, a doubling of the number of individuals presenting to our emergency room primarily for behavioral health needs, either substance abuse or mental health. And yes, it's true that the ER was expanding, but the overall visits of the ER increased only by 30%, while there was about 100% increase in behavioral health visits. As I mentioned, we could speculate on why that is, but I think that gets beyond the bounds of this particular talk. But I can say that there are certainly similar trends nationally. The result of this was long ER boarding times and the perception of inpatient bed shortages because we were admitting lots of these people. In fact, rightly or wrongly, and I'll talk a little bit about why this may have been the case, when we looked at the data, every person who presented to our ER for whom a psychiatry consult was requested, they had a greater than 50% likelihood of being admitted either to our inpatient unit or transferred to another acute inpatient unit in the state, which obviously led to our beds often being filled. There were a lot of consequences to this, both for the behavioral health clients in our emergency room settings, as well as for general clients. The people in our behavioral health clients were waiting. They weren't really getting treated, and they were spending longer and longer periods of time boarding, and I know that's a national issue. Very sadly, we were often transferring them long distances away from their communities, their families, and their natural supports. And in terms of the general non-behavioral health patients, from the ED perspective, because more and more of the ED beds were being filled by behavioral health patients for longer and longer periods of time, the number of patients who were leaving for any reason, who left without being seen, increased concurrently with the number of behavioral health patients. There was also a clear functional shortage of inpatient beds. That was obvious. At any given time, it was not at all uncommon and increasingly common for there to be literally not an open inpatient bed in the entire state of Iowa. And there started to be this drumbeat of we need more inpatient beds. And in my role in the consortium, the question that I was getting more and more was, tell us how many inpatient psych beds do we need? And they started this state task force over 12, 13 years ago now on getting that number right. Well, this may show my age, but when I was a kid, there was this song, you know, the foot bone's connected to the ankle bone and the ankle bone's connected to the leg bone. And my answer to the question of how many beds we needed was, that's not a reasonable question. That completely depends on looking at the whole. And the answer to the question of how many inpatient beds we need depends entirely on what the remainder of the array of services look like. And I talked about the fact that there were so-called front door and back door issues, i.e. What was leading people to either come into a hospital and what perhaps was preventing people from leaving a hospital once they came in. So one thing that we did was we simply took a look at all of our inpatient admissions over a period of about a little over a year. We looked at about 3,000 hospitalizations. And, you know, we usually focus on things like average length of stay and median length of stay, and those were our numbers. And when I thought about what that curve might look like, this was my expected, if I had a guess, in terms of the number of patients and the length of stay, I expected the curve to look like this, with sort of a median length of stay of about 5, and you know that's what I thought the curve would look like. Here's what the curve actually looked like. And just if you highlight, that just shows so that you can see a little bit, the modal length of stay. The most common length of stay turned out to be 2 days, followed by 1 day. What that told us is that probably all of those cases could have been diverted. So what are those cases? Those are people who are in trouble, who are having a very difficult time, a very difficult day, maybe intoxicated, come into the ER, you know, everything looks bleak, it looks like it's the end. We admit them, and they wake up the next day after getting a decent night's sleep, and all of a sudden the world looks a little different to them. But meanwhile, we've triggered this whole cycle of what we all know happens in inpatient psychiatric hospitals and a tremendous amount of resources. So that was by way of trying to raise awareness of the increased need for more meaningful crisis services, better front door or diversion from hospitalization services. And a whole other piece that we won't talk about here is all of the backdoor issues. But we tried to make the point that it was critical to have the right services at the right time. And the reason I'm going through this is because the things that I'm going to talk to you about today are all costly, and they take stakeholder investment, and you got to move that along. Maybe some of your communities are already there. Our community was not, our state was not. And it took a lot of work to sort of identify the important stakeholders and bring them along on the need for this type of greater array of psychiatric services. And we tried to help people recognize that the people who were sitting in our inpatient psychiatric units were not necessarily, and these are also stakeholders who may not be so close to what actually goes on in inpatient units. These may be policymakers, stakeholders, legislators, those kinds of things. And they may have this idea of who's sitting in those beds. But what we tried to make clear is that the people that we were seeing mostly in our inpatient psych beds were people who have multiple co-occurring, often chronic problems, including substance abuse, criminal justice issues, trauma, often complex and multi-generational, homelessness, joblessness, unemployment. Most people working in mental health recognize this. And what would happen in the ER is people were just hitting the wall. So people with these chronic, very difficult issues, life is hard. And at least in our state, in my community, we taught people that when you hit the wall, the place to go is the emergency room. And, you know, we teach people that when you have chest pain, it's important to get to the emergency room. When you have symptoms of a stroke, it's important to get to the emergency room. And that's great. And I don't know how it works in your community, but in our community, the emergency room was not such a great place to go when you hit the wall. It was a great place to go when you had chest pain, you know, that kind of thing. What tended to happen when people came to our emergency room is we basically either admitted them to our hospital or we sent them back to where they came from. And in reality, where they came from wasn't working, or they wouldn't have come to our emergency room. And this next slide is a recent paper that I would recommend to you. This is, just to see it, this is a recent article in Psychiatric Services. And basically, there's a kind of a dirty little secret that I think that this paper talks about that few other papers do, which is that hammer that we had, i.e., okay, you're presenting in crisis to our emergency room, we'll admit you to the hospital. Not only practically does that not really provide good solutions much of the time, but there's really quite limited data to suggest that inpatient hospitalization as we currently have them actually are effective for the kinds of, many of the kinds of conditions that we tend to admit people for. So we basically tried to propagate or disseminate to all stakeholders the model that, at least in my community and throughout my state, circa 2010, and really up until the last 2 years, we were living with, which is people would get into crisis, they were told to come to an emergency room, and the big fat arrows were either we admit them or we send them back to where they came from, either their family or natural supports, or very often in our community, law enforcement. Those were the two big places where people came. And we had relatively little connection with the kinds of services that were much more likely to be helpful to people in acute crisis. So we tried to sort of promote a vision in which the psychiatric hospitalization was just one arrow, but we had many other arrows going to places that might be equally or potentially more effective from when people presented in crisis. And that middle bar, we really didn't know what that was going to look like, whether that would be a hospital-based only or a community-based. And ultimately what we decided was that there was a role for both, that we needed to have a hospital-based psychiatric emergency capacity that was a whole lot better than what we had, and we needed to have a community-based psychiatric capacity for reasons that I'll explain. So the hospital-based took about 10 years. We had lots of starts and stops. We literally built a 6-bed unit right next to the emergency room that, for reasons that I won't go into here, but primarily financial, once it got built, we couldn't staff it. And we couldn't convince the powers that be that it was worth staffing it. And a couple of more years went by, and problems persisted. And finally, the powers that be, at least in our institution, were convinced that we needed to do something. And a year and a half ago, we opened our psychiatric emergency service. This is just an article that talks about it, that mentions some of the highlights that I'll go over, including the fact that it reduced the wait time for patients by about 80%. This is a brief view of what it looks like. You can see that we have a very open design. I should say that it's not contiguous with the ER. It's in a space that existed in the hospital that we basically converted to this space. We used Dr. Scott Zeller as a consultant, and he came in and helped us design it. This is the floor plan. So it's a open plan, no beds, just recliners that you can sleep in. Some open staff space. If I had my pointer, I would point to the top part of the green area, which is the open staff space. The part lower in your screen of the green area is an enclosed nursing station. We have 2 common rooms. This gives you a sense of the staffing. It's relatively staff intensive with 2 RNs on at all time. We have instead of having security in dressed as security as we used to have in the ER, they're in plain clothes, and they've all been cross-trained as to basically play support roles and are a part of the team, are not just there for when things go south, but are very proactive. We staff it with usually 2 psychiatric care providers, either MDs, nurse practitioners, or psychiatrically trained physician's assistants, 7 days a week, but not 24/7. We use our residents to cover over the evenings. It's quite social work intensive. And we have social work staff there 7 days a week. In terms of some of the most important outcomes so far, so this just shows that the number of patients who present primarily for behavioral health needs to our emergency room has stayed about stable since we opened it. The red arrow is the month that we opened it. And you can see a dramatic and persisting decrease in the amount of time that people are boarding or that these patients are sitting in the emergency department, which was one of our primary goals. How are we doing in terms of safety? Which was a concern of all of ours. I mean, we really try to admit a wide variety of patients. And in our hospital, code green is when things are getting dangerous, and we basically call security as well as a lot of reinforcements. And over the 18 months that we've been up and running, remarkably, I think we've had less than an average of 2 a month. We've had 0 seclusion and restraint use. That's been a major initiative in our hospital overall. In terms of assaults, we've had 1 patient-to-patient incident with no significant injury, 2 patient-to-staff incidents, thankfully with only 1 major injury. We've had only 2 incidents of patient self-injury, 1 by superficial cutting and swallowing. And I'm not seeing something on my slide, but I think there was something. Now, I think we do admit a wide variety of patients that are challenging. These are in our inclusion and exclusion criteria here. But it is the case that we certainly don't admit everybody. So we developed a protocol for deciding what medical instability looks like, and we don't admit people who we feel exceed that threshold. We don't admit people who we feel are actively delirious. If people are actively violent in the emergency department or are in need of seclusion and restraint down there, which happens, we wait until they've had at least a couple of hours of not being actively violent. We have some issues around our Department of Corrections folks. We wait until people are no longer clinically acutely intoxicated, and we are concerned and cautious with people who have histories of complicated withdrawal. Just briefly, our consumer satisfaction surveys have been really quite good. Of course, there's always a bias about who returns them. The main complaint I would suggest is because it's an open design, we don't really have a good capacity for having visitors, and that is a big problem. Sometimes we use the calming rooms and we allow visitors to come in there if we can do so in a way that they are not, basically having a lot of contact with the other patients. This is an important one, I think. What this basically shows is how are we doing on this issue of not admitting people necessarily to inpatient psych units. So we had been admitting about 55 to 60%. So we're still sending about 45% of people home or back to where they came from. We're able to resolve the issue from the ED. But we're only admitting directly from the ED less than 20%, and we're transferring very, very few. We're admitting almost 40% to the CSU from the ED. We have a low threshold for admission to the crisis stabilization unit. Once they get to the crisis stabilization unit, we're able to discharge about 70%. About 20% of those we're admitting either to our hospital, and another 9% we're transferring. So overall, we've cut our hospitalization rate to about 30%, which I don't think is quite good enough, but it's a big improvement to where it was, which was about 55 to 60%. Here's something that we're struggling with. So when we envisioned this, we had the hope that we were talking about less than 24 hours. That people would wake up the next morning, we'd be able to work things out, get them to where they needed to go. And what you see here is that our average length of stay is about twice of that. And we're struggling with it. There are still backdoor issues, and we can't magically resolve those issues within the time frame that we had hoped. Briefly, we are losing money in this service because payments for crisis stabilization are less, and we often are not getting paid for that second day. But the emergency department has increased their revenues by quite a bit, and significantly more than the overall CSU losses. I actually don't have the exact numbers for the CSU losses, or else I would have provided them. What I'm told is that the net increase from the ED definitely is greater than the cost for the CSU. How does the ED gain that revenue? Decrease in boarding time, and that leads very importantly to decrease in left without being seen rates for general patients, decrease in transfers, and just the increase in flow allows for increased medical and surgical hospitalizations. So if I'm just kind of looking back on this one, and then I'll get to the other, the emergency department loves this. We've had surprisingly few calamities so far. Patients appear generally calmer and much more respectful than they were when they were in the ED. It's staff intensive, can't have too much social work staff, need the right people at all levels. This is not the right atmosphere for every staff. We've had people who say, this is just too much, I can't do it. We have people who say, this is exactly what I was looking to do. And that is not just the psychiatric care providers, that goes for all levels, especially people like our security staff, our unit clerks. It's important to have the right spirit. One of the things that the leader of this unit has really conveyed is that the only firm rule we have is that there are no firm rules at this point. We take it person by person, case by case. It's not, as I said, this is hard work. I work there a couple of days a week, or actually, I shouldn't say that, about an average about 1 day a week. And it feels to me like we're doing most of what we did in a week's worth of an inpatient stay in 1 day. And sometimes it feels like that at the end of the day. It's not a panacea. We still need to connect people to services in a timely manner, which are often not available. So we still have backdoor issues. Because of that, we started a follow-up walk-in clinic staffed by the people who work in the CSU, which has been help. And as I said, we're still admitting 30% of patients to acute inpatient. I have a sense we can do better than that, get those numbers down. Again, it is not a benign thing to be admitted to an acute inpatient unit. It is not the best place to get better. and it can be a traumatic experience. All right, I'm going to spend a few minutes on the next model, community-based access system. And what I'm saying here is that this is really a change in culture that we're trying to do. Every time I call a behavioral health provider and I hear that voicemail that says, if this is an emergency, go to your nearest ER, I would hope to change that culture at some point. I'm not sure that the ER is where we should be instructing people to go. And we are trying to move the locus of crisis services out of the hospital and into the community. And that's this piece of it, at least as a part of the array of services. Again, very long process. We've been at this, we started this about 12 years. We did something that, for those of you who aren't far along in this process, I'd really recommend. It was a Dr. Ken Minkoff's suggestion. We brought him as a consultant 12 years ago. And he said, just start by coming together as a community. We formed a local county-based system of care group with voluntary participation from a wide variety of agencies and providers of healthcare and human services, just to come together on a monthly basis and sit around a table and learn each other's faces and maybe get each other's cell phone numbers and talk about next the common patient population that we were seeing. So as we all know, the patients that are most likely to present to the ED and behavioral health crisis are often those who are most likely to present to shelters, are often those who are most likely to find themselves in criminal justice settings. There's a lot of shared patients. And one thing that we did early on was we did a so-called FUSE project. We looked at our frequent utilizers of all of these services. And we did some cost analyses. And of course, we found that, the 80-20 rule, 20% of your patients account for 80% of your costs. And then if you take that 20%, the 80-20 rule applies there too. And if you take that 20%, the 80-20 rule applies there too. And at the very top of that pyramid are, within every community, identifiable numbers of patients who are costing a tremendous amount of resources, which wouldn't be so bad if their outcomes were decent, but are not showing decent outcomes. And this was one of the most potent strategies that we used to convince stakeholders of the need for this kind of service. We looked at some of our highest utilizers, talked about them clinically. They weren't doing well despite the untold dollars that all of these various siloed agencies were pouring in. And that group worked on a variety, got to know each other, came together, stayed together, put in many grants, almost all of which were unfunded. But we started developing a shared vision and a shared voice, and we started influencing our various communities towards some common goals. And one of the things we really tried to get the message out about is that we wanted a third option in addition to basically the emergency room and the jail. We wanted a different option. We wanted a central non-hospital-based campus in which to integrate health and human services, especially targeted to highest utilizers, but open to the entire community. And we wanted that to divert, hopefully, from higher cost and less effective services. And very importantly, we wanted to both demedicalize and decriminalize behavioral health crisis when we could. And this is sort of an early schematic of what we were envisioning. We wanted to have good evaluation capacity. We wanted a place for people to just sober up. We needed more detox beds in our community. We wanted the 23 to 46 hour observation capacity. We wanted a place where people could stay a bit longer, maybe up to a week if necessary. And we also, in our community, we have a so-called high barrier shelter, i.e., you can't be acutely intoxicated to get into our shelter. So we wanted, in this same building, the capacity for a low barrier shelter, especially in winter months. And we envisioned a variety of inflow tracks and a variety of outflow tracks. And it wasn't cheap. So we projected initial capital costs of 5 to 10 million and projected annual budget of around 4 million. And we expected a big loss. We did not expect that annual operating budget, which was a conservative estimate, would be reimbursed by traditional payers. So we needed additional revenue. And we basically cobbled together through a long process of making the case for this. Surprising to everybody, we cobbled together capital funding. We went to our municipalities primarily and made the case in all of both the main little cities in our county as well as the small towns and the region. And we cobbled together about $8.5 million for capital funding. And the services that we promised were crisis observation, 10 beds, crisis stabilization, another 10 beds where people could stay up to 5 days, a sobering unit, and additional detox beds. We have mobile crisis, which started in our community about 5 years ago. And we will bring them into this building, and they will be an important part of the staff that work in this program. They will continue to do their outreach, but they will also then be able to bring them back home to this one integrated campus. And on site will be this 40-bed winter shelter, low barrier. Just briefly, it was tremendously gratifying after spending 10, 11, 12 years with this group of multidisciplinary stakeholders to actually get to put the pieces of this together. This is us sitting with our architect, literally like a jigsaw puzzle, visioning what we wanted in this building, what we needed in this building. And eventually we had a floor plan, which I won't go into, and we got the site that we wanted, which is catty corner to our shelter and directly to the west of our substance abuse treatment provider. We had no not in my backyard issues because this is already sort of a campus model, so we wanted it to be connected to other key human service areas, and we got it. I know my time is getting limited, so I will just say that this was really a collaboration and continues to be a collaboration between a wide variety of agencies that would not have happened if we hadn't developed these relationships over time. That's our branding. We are the GuideLink Center, Immediate Access to Mental Health and Substance Abuse, and this is a schematic of what the building will look like. This is our timeline, so this is just getting up and running. We awarded construction. We hope to open in the fall of 2020. We hope to hire staff very soon. So I'm going to end with what keeps me up at night about this. The biggest one, of course, who's going to do this work? You need the right people, the right spirit, the right leadership. And if we're able to recruit, can we retain? How are we going to prevent burnout? How are we going to support these people? Our peer support is going to be key in terms of our workforce. And we're hoping to do a cross-training so that basically as many people in the building as possible, staff, can help each other out. Financial stability. We were able to cobble together capital costs, but we're expected to be solvent based on third-party funding. We actually know that's not going to work. Crisis rates are lower than hospital rates. My big concern is that if we start bearing down our staffing because of ongoing costs, then we're not going to be able to support the staff. We're not going to be able to keep the good staff because nobody's going to work in an environment where they don't feel that they're doing the job that they need to do. And one thing we've learned in our hospital-based unit is, as I said, very social work intensive. You need people there to do the work. Balancing safety and risk. This is not in a hospital. I can't call a code green and have 15 people, including security, there immediately. But if we don't take quote unquote challenging or difficult people, we're not going to be viable. The police aren't going to waste their time with us if we don't take real patients, real people who are experiencing crisis. We're not going to have seclusion and restraint capacity. We're going to have to call the police back for unmanageable agitation and violence. And believe it or not, at this late date, we're still working out policies regarding how we're dealing with involuntary patients. The collaboration is nice in terms of spirit, but there are lots of challenges. And one of them is that should say EHR, not HER. So each of our major agency partners in this is committed to maintaining their individual electronic health records, EHRs. And so we're now doing the hard work of figuring out how to integrate these and avoid redundancies and track key performance metrics and outcomes by pulling data not from one system, but from 4. I'll just briefly say we are following Dr. Balfour's guidelines in terms of the outcome metrics that we're using. I won't go into this, it's detailed in her presentation. Other risks of starting too quickly rather than phasing in. I worry that just like self-driving vehicles, one accident could really derail things. If we have an early calamity, that could have major impact. I worry that there may be a regulatory fiasco, like someone deciding that because we have more than 16 beds, we're an IMD. And unfortunately, the state has already, in their wisdom, mandated 6 of these statewide, even though we haven't figured out the kinks in any one. So I would rather do it one at a time. Very quickly, we want a culture shift. No more voicemails that necessarily say you have to go to your nearest emergency room, but there are other options. Behavioral crisis services less medicalized, meaningful diversion from both criminal justice system for mental health and substance abuse problems, no more big bond issues for jails, and importantly, use inpatient psychiatric services more appropriately for high-risk, imminent dangerous behaviors and medically fragile and complex and behaviorally mental health fragile and complex patients. I hope it becomes a magnet for multidisciplinary training and thoughtful, slow replication and adaptation and community empowerment. So I hope this is helpful to show just one community's example of how we built these services. I don't say we have all the answers. I do think the answer that I would recommend to you most is, if you haven't done so, build a community systems of care group, get to know each other, figure out who your community is, work with each other through that frustrating process. Use the tools that were presented in the first and second webinars in this series to figure out how they apply best to your community. And my apologies, because I was supposed to leave at least 5 minutes. So I will stop here and leave the remaining time for concluding remarks.
That is quite all right. That was a lot to cover in a limited amount of time, and it was all incredibly valuable information. So I appreciate you using that time wisely. I just want to say thank you once again to our content expert, Dr. Flaum. This was incredibly valuable information from the ground to see how can our communities in the Pacific Northwest region emulate what you're doing in Iowa and really take the pearls that you've learned along the way and use them to make our services better here in our region of the country. Thank you again, Dr. Flaum. This was phenomenal.
Thank you very much.